Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more pathology videos. Today, in this video, we will discuss a hematology topic, RBC abnormalities, which is very important for theory and practical point of view. So, RBC anomalies are anisocytosis, poikilocytosis, anisochromasia, and abnormal inclusion bodies in red blood cells. First, anisocytosis. It is increased number of red blood cells with variation in size. Poikilocytosis, increased number of red blood cells with variation in shape. Anisochromasia will be variation in the pigmentation or coloration of the red blood cells. Whereas abnormal inclusion bodies in red blood cells will be because of the presence of stainable substances or materials. Anisocytosis is increase in the size of the red blood cells. Normocyte or discocyte, microcyte, macrocyte, and megalocyte are the various terms used for red blood cell based on their size. First, normocyte, it is also called as discocyte. It is a normal erythrocyte. Approximately the size of the nucleus of a lymphocyte is equal to a normal erythrocyte. It is around 6 to 8 microns. And the mean corpuscular volume or MCV will be 80 to 100 femtoliters. And the condition of normocytes is called as normocytosis. It is seen in hemorrhage and hemodilution. Next one is microcyte. The size of the red blood cells will be less than 6 microns and MCV will be less than 80 femtoliters. And the condition is called as microcytosis. There will be lack of necessary basic materials that are needed to develop a cell that results in a microcyte. Examples are sideroblastic anemia, iron deficiency anemia, thalassemias, anemia of chronic disease, and lead poisoning. Coming to macrocyte, the size will be more than 8 microns and it is in between 8 to 12 microns. And the MCV will be more than 100 femtoliters. They are normal in newborns and the condition is called as macrocytosis, seen in vitamin B12 deficiency, folic acid deficiency, in all nutritional anemias, hypothyroidism, and few drugs intake. There will be accelerated erythropoiesis. Coming to megalocyte, if the size of the red blood cell is more than 12 microns, then it is called as a megalocyte and the condition is called as megalocytosis, which is seen in megaloblastic anemia. Now, what is the difference between the terms? We have to be very thorough as they may ask you in the Viva questions. What is dimorphic population or what is the term used when two distinct populations of red blood cells are seen? It is dimorphic anemia or dimorphic population. In this dimorphic population, you can see the red blood cells can be both normocytes and microcytes, or normocytes and macrocytes, or microcytes and macrocytes. Any combination of two types of red blood cells can be seen. Now coming to poikilocytosis. A poikilocyte is an abnormal shaped cell. There may be variations in the shape or there may be variety of pathological conditions that are related to poikilocytosis. Under the poikilocytosis, we have acanthocyte, burr cell, echinocyte, elliptocyte, blister cell, helmet cell, pycnocyte, sickle cell, spherocyte, stomatocyte, cystocyte, dacrocyte, target cell, racket cell, bite cell, and pincer cell. In the practical viva, they may ask you to draw a diagram of this type of cell or they want to explain these type of red blood cells. So we will have the discussion in detail. acanthocyte or thorn cell or spur cell or stellar cell or astrocyte. They are rounded RBCs with 5 to 10 spicules, and there will be irreversibly thorny appearance because of the permanent cell damage. And these are seen in lipid metabolic disorders and severe liver disease. Next is echinocyte, also called as Burr cell. They will have irregular sites with knobby projections with shorter spines or spicules, and they are seen in uremia. Crenated cells, these are having 10 to 30 sharp blunt spicules which are evenly distributed on the surface. They are not clinically important, and they are seen in improper smear preparation and artifacts during smear preparation. Coming to elliptocyte or ovalocyte, elliptocytes are cigar shaped and ovalocytes are egg shaped, seen in hereditary elliptocytosis and iron deficiency anemia. Cystocytes are schizocyte or RBC fragments. Sh- Schis prefix indicates cut. So these are disintegrating, damaged or fragmented red blood cells with many shapes and sizes, resulting from the passage through damaged or altered blood vessels. And these are seen in burns and disseminated intravascular coagulation, also called as consumption coagulopathy or DIC. Next is blister cell. These are singular multiple vacuolated cells with markedly thin areas at the periphery. Trauma during passage to partially obstructed blood vessel will result in a blister cell, and they are seen in burns and damaged blood vessels. Helmet cell or keratocyte of basis or triangle cell or a horn cell. They are hollow interior resembling a helmet or horn, and they are caused by a hemolytic process, and so they are most frequently seen in all hemolytic anemias. White cells are degmocytes. Due to removal of the hinge bodies by the pitting action of the spleen, these bite cells are formed, and these are the classical or characteristic features of G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency, that is leading to anemia. Pycnocyte, these are distorted, contracted, spiculated red blood cells, and most commonly seen in uh, normally in 2 to 3 months babies, and it is called as infantile pycnocytosis when these pycnocytes are more than 50% in number. Sickle cell, also called as drepanocyte or meniscocyte, they are having thin elongated pointed ends, and they are crescent in shape, curved blade, holly leaf-like appearance, and they contain hemoglobin S, and these sickle cells are seen in sickle cell anemias, hemoglobinopathies. Spirocyte, nearly spherical, smaller in diameter, lack central pallor, and they are seen in hereditary spherocytosis, burns, and autoimmune hemolytic anemia or AIHA. Poikilocytosis. Under this poikilocytosis, there is a cell called as mouth cell or stomatocyte, which will have slit-like area of central pallor, and these stomatocytes are most common in hereditary stomatocytosis, and they will indicate the liver disease. Teardrop cells or dacrocytes are having tapered and rounded end, and they are seen in pernicious anemia and thalassemias. Racket cells, these are having pear shape like teardrop cells but with a longer tail, appearing like a tennis racket. Implications are like teardrop cell. Target cell, also called as leptocyte or platycyte or codocyte or bullseye cell or Greek helmet cell and Mexican hat cell. They show a central area of hemoglobin surrounded by a colorless ring and a peripheral ring of hemoglobin. They can be cup shaped or bell shaped, and they are considered as artifacts and seen in iron deficiency anemias and hemoglobinopathies. Insert cells are mushroom shaped cells treated as spherocytes. Coming to anisochromasia, that is variation in the hemoglobin content. The red blood cells can be called as normochromic or hypochromic or hyperchromic or polychromic or annulocytes or target cells based on the MCH and MCHC. Normochromic or orthochromic, they will have normal hemoglobin content. There will be one third central pallor. In hypochromic red blood cells, there will be decreased hemoglobin. MCH and MCHC are decreased. The central one third pallor will be more than one third. Usually, microcytes will show hypochromasia seen in iron deficiency anemia and thalassemias. Hyperchromic or spherocytes, they will have no central pallor. Polychromic, that is patchy distribution of the red blood cells. These will stain slight blue orange color with the right stain, and polychromasia is seen in reticulocytosis and slightly macrocytic conditions. Annulocyte, also called as ghost cell or pessary cell, RBCs having a thin rim of hemoglobin and a large central area, and target cells. Abnormal inclusion bodies. These abnormal inclusion bodies of red blood cells can be Howell-Jolly bodies, Cabot rings, basophilic stippling, hinge Ehrlich bodies or hinge bodies, Pappenheimer bodies, malarial stipplings, hemoglobin crystals, hemoglobin H inclusions, and nucleated red blood cells. Howell-Jolly bodies are spherical and they are nuclear remnants in red blood cells. They may be single or multiple and stain reddish blue to purple. Howell-Jolly bodies are seen in hemolytic anemias and pernicious anemias. Cabot rings, thread, blue ring-shaped twisted figure of 8 cytoplasmic inclusions are called as Cabot rings, and they are seen in severe anemias and lead poisoning. Basophilic stipplings, these are multiple fine or coarse RNA inclusions, and they will not stain with Prussian blue stain, and they are seen in lead poisoning. Hinge Ehrlich bodies or hinge bodies are multiple inclusions from the denatured hemoglobin. They are membrane bound and are seen in G6PD deficiency. They stain with crystal violet and crystal blue stain. Siderocytic granules are Pappenheimer. Remember hammer, Heimer, iron. Iron granules clustered at one end. Dark violet in color seen in sideroblastic anemias. Malarial stipplings. The granules formed by malarial parasites will result in malarial stipplings. They can be called as Kuffner's dots or Siemens dots or Morrow's dots or Christopher dots, seen in Plasmodium vivax or Falciparum or malarial infections. Hemoglobin crystals are rod-like, angular, opaque, often curved reddish brown hemoglobin crystals with a Washington monuments, seen in hemoglobin C disease. Hemoglobin H inclusions are small greenish or bluish bodies and formed due to instability of hemoglobin H in the supravital stains, seen in hemoglobin H disease. Nucleated red blood cells. These are normal blasts or orthochromic normoblasts seen in marrow stimulation and normal in newborns. And under the miscellaneous conditions based on the RBC appearance, There may be a Rolex formation or agglutination. In the examination, practical viva, they will ask you what is the difference between a Rolex formation and agglutination. Rolex formation is arrangement of red blood cells in rolls or stacks of coins, and they are not clinically significant. They are mistaken for true clumping. Coming to agglutination, they are irregular and round clumping. They are seen in cold agglutinin disease and autoimmune hemolytic anemias. Thank you for patient listening. Once again, I request all of you to like, share, and subscribe Dr. Ravichandra Official for more interesting pathology videos.